We used 5-methylfolate, but what we did is we had her start on a low dose. Typically for a COMT patient, I like to see them start at around 200 micrograms. And for most patients, 200 micrograms is a relatively good starting dose for 5-methylfolate. And I say for most patients because one of our patients here at the retreat this week started out on 200 micrograms and crashed miserably. I have a patient in Denver who started out on 100 micrograms of 5-methylfolate and crashed miserably. And to me, those are signs of possible environmental toxicity. And it turns out that our gentleman in Denver that crashed miserably on what I call a hummingbird's dose of 5-methylfolate grew up in a Superfund site, and he was exposed to 62 different chlorinated organic molecules for a large part of his childhood. Okay, so LDH. The reason that the LDH is important to me, and we'll come back to this when we get into the pathways, when we start talking about energy utilization, is LDH is lactate dehydrogenase, and it is generally expressed in times of anaerobic exercise. But when you have a patient who has cancer that's not exercising and they're expressing LDH, that can be a sign of what I refer to as a bastardized Cori cycle. And we'll come back to that and cover this in pretty good detail. But to me, an LDH of 219 is relatively high for a cancer patient, because if a cancer patient is expressing large amounts of LDH, it means that their liver is starting to be hijacked by their tumors. And we'll look at that in a pathway and actually cover that in detail. But to me, LDH greater than 175 can be really bad sign for cancer patients, especially if their fasting glucose is greater than 90. And this, I wanted to show multiple labs in 2014 because this woman was cruising along with a really beautiful, low glycemic, high diet rich in whole foods. She was avoiding starchy vegetables and cruising right along for about a year and a half with a fasting blood sugar of 88. And then when her sister died, to me, this is absolute adrenal meltdown. And so remember that when you have patients that are eating a really good low glycemic diet, especially important for cancer patients, but when they're eating a low glycemic diet and their fasting glucose doesn't budge, and you know that they're being compliant, this is the time to talk about stress management and find out, is there some event that precipitated this? Because to me, this is another manifestation of COMT, because COMT metabolizes epinephrine. And remember that epinephrine tells the fasting liver that the peripheral tissues need glucose. The other thing that stands out to me for patients in terms of their SNPs is calcium, and her calcium has been great. I am particularly vigilant of calcium for patients that tend towards anxiety. And when we first started seeing Peggy, her calcium was in the range of 9.6, and she was really not accommodating stress well. And a lot of that has to do with the role of calcium in neurological impulse proliferation. And remember that NMDA receptors are excitatory neurotransmitter receptors, and so remember, and we'll talk more about NMDA, but NMDA receptors are important for excitatory neurotransmission. They're calcium channels. And so when you're overloaded with calcium, even when your NMDA receptors are functioning correctly, your central nervous system is probably going to be in a hyper-excited state if you're high in calcium. And so for patients that have a history of depression or anxiety, to me a calcium of 9.6 is high, and we gave her some pretty significant doses of vitamin K